So good evening and welcome to Decisions and Dilemmas in Prostate Cancer Management. I'm Rob Dreicer from the University of Virginia, and we'd like to thank the Medical Learning Institute Peer Review and the Prostate Conditions and Education Council for providing this session, and Astellas, Pfizer, Exelixis, and Janssen for educational grants. Please take the pre-event survey on the iPads. And if you have questions, you can submit them throughout the meeting, and we'll try to get through them. These are my disclosures. I am pleased to be joined by two friends and colleagues, the good Dr. Barata from Tulane University, and these are his disclosures, and the good Dr. Beer, who is going to be available to us virtually. Dr. Beer has in his contract that he needs to be 500 miles away from me, so he's probably in Portland. I think that fulfills the distance. Does it right, Tom? Are we fulfilling our distance? All right.
Yes, we are, and I'm a little farther away than that, Rob.
All right, so fair enough. I'm glad we are consistent with your needs. All right, disclosures and disclaimers, and here is the place where you can get the slides and practice aids and download them after the event. So let's get started. So 2022, clinical states of prostate cancer. I want you to look at the reference, Scher et al. Urology 2000. I saw Dr. Scher earlier this morning. This is not the way he published it originally, but he and his colleagues, I think, were at the forefront of how we begin to think about prostate cancer as a heterogeneous disease. And again, you could modulate this clinical states model in any way you want, and it's going to continue to evolve. But it goes back to his and his colleagues thinking about the disease and beginning to subset the disease. And increasingly, we're going to manage this disease and try to come up with ways to deal with the heterogeneity. There are clearly challenges as we evolve management. And this is some data in a couple of buckets about what we're not doing. I'm not going to read through all this, but one of the challenges, and it came up in discussions in the prostate cancer sessions yesterday, that when you look at real-world data and just think about intensification in the context of hormone-sensitive metastatic disease, in the US, we do a very poor job, and there are estimates that only 30 or 40% of patients are actually receiving intensified therapy, despite really compelling level 1 evidence that's about a decade old. So we have work to do. There are a lot of patients who are just not being managed with level 1 evidence, and part of the way to overcome that is just, frankly, education. So the Prostate Conditions Education Council, or PCEC, is a group that leads in prostate advocacy. It's more than prostate cancer. It's been around for a long time, and you get a sense of their reach and the extent of views on their websites, and we're going to hear more from them throughout the program. So again, prostate cancer, when you think about solid tumors, is not only extremely heterogeneous in terms of the disease state, but it's also managed very differently than other solid tumors. There are medical oncologists who practice in the community. There are academic urologic medical oncologists. We have community urologists. We have urologists that practice in large urology group practices. Some of them have advanced prostate cancer clinics with significant sophistication, and we have our colleagues in radiation oncology, both in the academic setting and in the community setting. And there are some divergent differences in practice based on who's managing the patient, based on their perspective and their training and experience. Remember, the hormone-sensitive or castration-sensitive disease doesn't always mean hormonal naive. There is an impact of the leftward movement of therapeutics, the intensification, moving a lot of therapies we used for mCRPC earlier. We're going to touch on a little bit about the impact of next-generation imaging tonight. PSMA, PET-CT is here in the US, slower than, of course, the rest of the world, but now we're beginning to be impacted on what the implications of that are. Likely within a very short period of time, we're going to have an agent that's a therapeutic, a theranostic, that both imaging and therapy. Issues of oligometastatic versus polymetastatic disease, the addition of local therapies to metastatic patients, and the significant impact of prostate cancer genomics. So this is how we're going to break things down. If we have a case we're going to present, we'll touch on it a bit. 60-year-old man seeks your input on management 5 years prior with a PSA of 12. He had a trust biopsy with a Gleason 7. He undergoes a prostatectomy. He's got Gleason 7, tertiary pattern 5, PT2, biochemical failure relatively shortly thereafter, salvage RT when his PSA was 0.23. 3 years ago, he had a solitary MET that was biopsy proven, and he got that radiated, and he got 6 months of ADT at the same time, concurrent and then subsequent. He's asymptomatic now, but his PSA is 66. His ECOG is 0. He's a little anemic. His chemistries are fine. His T is 455. He has bone mets on imaging with CT scans. He also has a bone scan done, and it is abnormal, as you can all see. All right. I'm going to now ask my colleague, Dr. Beers, to sort of provide us an overview on the role of metastatic castrate-sensitive prostate cancer. Dr. Beer.
Thank you, Dr. Dreicer. It's great to be here with you and Dr. Barata, and I look forward to discussing this case further as we go through some more relevant data. So when we think about therapeutic decision-making in patients with metastatic castration-sensitive prostate cancer, there are a number of clinical factors that come into play as we make individual patient decisions. And in this slide, we tried to summarize some of those factors. Clearly, fitness for relevant therapies is a critical component. So fitness for chemotherapy, fitness for androgen receptor targeted therapy, specifically for abiraterone as it relates to blood sugars, cardiac history, liver disease. Prior therapy can be a consideration. That's more, of course, relevant to recurrent disease than for newly diagnosed metastatic disease. And occasionally we encounter patients that present in a manner that makes us consider the possibility that they're not particularly AR dependent. Poor PSA expression, for example, or presence of liver metastases can be associated with a lower response rate to hormonal maneuvers. And then there's volume of disease, low volume and high volume. We'll discuss that a little bit more in the upcoming slides. But the evidence for androgen receptor inhibitors and abiraterone is available across groups of volume of disease. But for docetaxel, the data are more compelling for high volume disease. So as we approach a patient and think about choosing a treatment plan, some of the things that obviously we might consider are laboratory tests evaluating PSA, hemoglobin, red cells, chemistries, liver function tests, electrolytes, kidney function, assessment of symptoms. Is there bone pain? Are there new or emerging or rapidly progressing symptoms? What's the patient's energy level? Is there a history of medical conditions that might interfere or predispose a patient to side effects from one of the agents we're considering? And then imaging results, typically in this case, conventional imaging, is the disease in lymph nodes, bones, visceral organs, and especially in the liver. One of the issues in the field is the volume of disease, and there's a number of considerations here. You may have heard the term oligometastatic disease thrown around, and it can be considered both with regard to the type of systemic therapy that we would recommend, and occasionally also in considering lesion-directed radiation therapy to metastatic lesions. And so you can see some of the evidence that is available that shows that volume of disease matters. And so you can see in the top panels, low volume of disease and high volume of disease, and the probability of CRPC-free survival or absence of the development of castration-resistant disease. Clearly, much faster progression to CRPC with high volume disease. Location of disease matters. On the right-hand side, you can see a couple of different analyses that demonstrate, as we consistently have come to expect, that patients with lymph node-only disease tend to do better, patients with liver metastases do worse, and patients with lung or bone metastases fall somewhere in between. And in the classification and regression tree that you can see here, there is a look at prostate cancer-specific survival in patients with a single metastasis versus multiple metastases, further subdivided by PSA doubling time. And you can see clearly very distinct groups with regard to 5-year prostate cancer-specific survival. Now, in this slide and the next, I wanted to briefly introduce you to the portfolio of clinical trials that have defined the optimal care for this patient group. First, a series of clinical trials that examined docetaxel chemotherapy. 2 of these trials, Charted and Stampede, had adequate power to look at survival endpoints, and both of those clearly demonstrated the value of docetaxel in addition to hormonal therapy in metastatic castration-sensitive prostate cancer. Since then, we've had a series of trials that have examined the next generation hormonal agents, with Latitude and Stampede examining abiraterone, Arches and Enzamet examining enzalutamide, and Titan examining apalutamide. And again, all of these studies yielded positive results and provide evidence of support for doublet combinations in the initial management of metastatic castration-sensitive prostate cancer. You can see in these busy tables the detailed results. Those are here for your reference. We won't be going through them in detail in this talk. I did want to show a couple of examples and dig a little bit deeper in a couple of areas, so I wanted to show you the phase 3 Arches clinical trial. This was a study of enzalutamide or placebo in addition to androgen deprivation therapy for newly diagnosed metastatic castration-sensitive prostate cancer. Patients were stratified by volume of disease and by prior docetaxel therapy, with the endpoints of progression-free survival and overall survival. Recently, at ESMO 2021, we saw the presentation of the overall survival results of this trial that were not available with the initial reports that focused on progression-free survival. And you can see that treatment with combination therapy with enzalutamide and ADT yielded a significant improvement in overall survival. You can see the various landmarks at 24, 36, and 48 months. The median follow-up at the time of this analysis is 44 months, and the number of deaths were 154 in the combination arm and 202 in the single agent ADT arm. So we recently heard the results of the PEACE-1 trial, one of the first trials to examine triplet combinations. We do have some data on triplet combinations from prior studies. For example, Arches had a small fraction of patients who received prior docetaxel, and Enzamet had a significant proportion of patients who received docetaxel. Those trials didn't really yield supportive results for triplets, but PEACE-1 provides us some new and important information in this regard. PEACE-1 was a 4-arm trial that examined the question of adding abiraterone acetate to the standard of care and also adding radiation therapy to the standard of care. And the standard of care evolved over the duration of this trial. Initially, hormonal therapy alone, subsequently hormonal therapy plus or minus docetaxel at the discretion of the treating physician, and finally, ADT and docetaxel was the standard of care arm in this study. This enabled a look at the role of abiraterone in patients who also received docetaxel. And these are the initial results of those analyses presented in 2021. So you can see that in the subset of patients who had de novo metastatic castration-sensitive prostate cancer and who received docetaxel, overall survival was improved with the addition of abiraterone. And at the median, the improvement was from 4.7 years to 5.7 years, with a hazard ratio of 0.82. So that's one of the first results that demonstrates that 3-drug combinations hold promise when compared to 2-drug combinations, particularly when that 2-drug combination is that of docetaxel. As we saw presented yesterday, another trial speaks to this question as well, and that's the ARASENS trial. The ARASENS trial looks at 3-drug combinations of ADT, docetaxel, and darolutamide compared to ADT plus docetaxel plus placebo. The trial planned to randomize 1,300 patients to these 2 treatment arms. And we heard yesterday that it met its primary endpoint of significantly increasing overall survival in patients with metastatic castration-sensitive prostate cancer. And I look forward to further discussion of the impact of these results on practice with my colleagues today. Now, as we contemplate these multi-agent therapies, I wanted to leave you with some thoughts about side effects and patient preferences. So, of course, we're all familiar with hot flashes, fatigue, and loss of libido and sexual toxicity of hormonal therapies. But as we intensify therapies with the addition of second agents such as apalutamide, enzalutamide, and abiraterone, we also need to increasingly concern ourselves with hypertension, cardiovascular complications, back pain, sarcopenia, weight gain, and others. So these are some of the considerations that come into play as we consider patient preferences with regard to initial management of castration-sensitive prostate cancer. And of course, patient preferences regarding the therapy regimens are important as well. There are decisions about shorter courses of therapy with docetaxel where the second agent is delivered over an 18-week period and treatment is done and ADT alone is continued, versus long-term therapy with the hormonal agents. Some patients really prefer not to take pills daily. Other patients, of course, have strongly held views about chemotherapy. The perceived as well as actual impacts on quality of life are important, as of course are cost of therapy and economic consideration. We do now, however, have compelling level 1 evidence that nearly all patients with metastatic castration-sensitive prostate cancer should be receiving combination therapy, at least with doublets of chemotherapy and hormonal agents, and in some cases, perhaps triplet combinations. Thank you very much for this opportunity to have this discussion. I'd like to pass the baton back to Dr. Dreicer.
Thank you, Dr. Beer. So let's remind ourselves that despite what Dr. Beer just presented, which is really compelling evidence, and we saw more yesterday, that, again, ADT intensification is really underutilized in real-world practice. This data comes from a population-based study within the VA system, and it showed a relatively low uptake of any of the novel ARs or docetaxel. And as we all know, the VA system is actually a relatively good place to look because it is, in a sense, real world. It is, for the most part, as it is not an economic issue, it's a matter of being offered a therapy. So we have challenges to work through. So let's go back to Mr. B. This is a 60-year-old guy, remember, who had biochemical failure, got salvage radiotherapy with 6 months of ADT, develops what on conventional imaging appears to be a solitary bone met, gets it biopsied, gets it radiated, he gets the ADT in this context, not in the biochemical failure setting. He's asymptomatic with a PSA of 66. CTs show bone mets, and the bone scan shows widely metastatic disease. So this particular thing allows me to remind you to complete the polling questions in your iPad. I want you to know that Dr. Barata's honorarium is tied to the completion rate, and he needs the money. So please make sure you finish these things. I'll remind you again. Anyway, so before we talk about this case, Dr. Beer, that gentleman with the oligometastatic disease that got radiated and got 6 months of hormones, now has got, you saw that bone scan, pretty extensive disease, but he's relatively asymptomatic. So what's up? And his T is recovered.
Sure. Sure. So, when you think about a patient presenting with metastatic disease, I think there are two factors that drive prognosis and treatment choices from the disease perspective. One is this de novo disease, newly diagnosed initial presentation of metastatic disease, or is it recurrent? In this case, the patient's got recurrent disease. And the other is the volume of disease, high or low volume. There's a couple different definitions. I use the charted one. This patient clearly has high volume but recurrent disease. So recurrent is favorable, high volume is unfavorable. He falls kind of in the middle of the four-quadrant prognosis diagram, if you will. I think in this setting, he clearly should consider combination therapy. As we've discussed, the data are really, really compelling. And which one to choose really ends up being a question of comorbidities and patient preference, physician preference. And I don't know if you want me to dig into the triplet discussion at this point, or if you want to take that a little bit later.
Well, I think we can touch on it just briefly. I mean, the piece one data, of course, is de novo presentation. And as we saw with Arison's yesterday, at least at the time of the presentation, my recollection, and you guys can correct me if I'm wrong, was 90-something% were de novo in that presentation. So again, it's another de novo setting. So one could argue potentially that neither of these studies speak to this gentleman. What's your thoughts about that?
That's right. Fully agree. A great presentation, Dr. Beer, by the way. And I fully agree with Dr. Beer's comments. I think, in the context of recurrent high volume disease, I think it would be appropriate to consider triple therapy, although we cannot, assume all patients enrolled in PIS1 and Arison's actually would use that data to justify doing, DOSI with darolutamide or DOSI followed, in abiraterone, right, in combination with ADT. I would argue in a lot of scenarios, a lot of us would still consider novel hormonal therapy in addition to ADT, right? Thinking of what Dr. Beer just said regarding recurrent disease and not being de novo, the fact that the patient does not have visual disease, the fact that the patient, doesn't have symptoms, right? And so in that setting, whether you pick abiraterone or enzalutamide or apalutamide, all of them would all improve clinical outcomes, would be reasonable options, in my opinion. Yeah.
All right, let's move on. So actually, I'm going to go back to the case before I introduce Dr. Barata. So again, this is a non-metastatic setting. Mr. G, 62 years, 4 years out from a radical prostatectomy for a T3B, Gleason grade group 4 disease. He's got right seminal vesicle and perineural invasion, negative surgical margins. His initial PSA was 9.2. A year later, he gets salvage radiotherapy with 6 months of ADT. You see his PSA at time of treatment. Now his PSA is 1.25. It's up from a nadir of undetectable. He's got castrate levels of T, ECOG 0, no real comorbidities. His conventional imaging are unremarkable. So with that, I'm going to ask Dr. Barata to talk to us about issues for castrate-resistant prostate cancer.
Great. Thank you so much, Dr. Dreicer, and it's a pleasure to be here. Thank you for the invitation. Thank you all for being here with us, live and also, virtual. So we're going to change gears here a little bit. So we're going to move from the metastatic hormone-sensitive space or castration-naive space to the non-metastatic space, CRPC, if you will. And some of you might be familiar with this data from Dr. Smith. That basically shows, this is actually a kind of a subgroup analysis of a trial that took patients, over 200 patients with non-metastatic castration-resistant disease, defined by conventional scans. So rising PSA, no disease in CT and bone scan, and over 200 patients. As you can see in this slide, represented on the left, absolute numbers of PSA, and then on the right, the doubling time of PSA. So the higher PSA and the shorter doubling time are associated with progressive disease into new mets, right? And now we know that endpoint, if you will, as metastasis-free survival, right, is the time when you do actually develop metastatic disease. So this is a good reminder, and it's actually the backbone of what I'm actually going to show you next. That is a number of phase 3 trials, 3 of them, right, all of them with a very similar design, all phase 3, combined with comparing anti-androgens, Prostate study enzalutamide, Spartan study apalutamide, and then Aramis study darolutamide, all against placebo in this patient population of non-metastatic CRPC that was defined with a PSA above 2, with a doubling time of fewer than 10 months, right? So this is not all the patients we see in clinic, but definitely those where, as I showed you before, with a moving PSA and shorter doubling time. So, and the data in terms of efficacy seems remarkably similar, right? In other words, if you bring an anti-androgen in addition to castration, you're able to significantly prolong time to disease in the scans, or in other words, you've significantly prolonged the primary endpoint, which was metastasis-free survival. There was a lot of conversations around that endpoint, whether or not it would predict improvement in overall survival. So, whether or not it was a surrogate for OS, but as you can see here, a significant, risk reduction. And we're talking roughly, about, it goes from 14 to 18 months or so, where you expect to be on hormones until you develop disease in the scans, to close to 40 months or so if you bring a novel anti-androgen, right? And that was, as I said, all these landed in New England, all 3 New England papers. And then what was nice about it is actually we had the chance, the opportunity to confirm the translation of MFS, metastasis-free survival, into OS. And voila, we have that data here as well. We can see pretty similar data as well in terms of overall survival, with the risk reduction, around 20 to 30%, if you will, favoring the combination of an anti-androgen with ADT. And this became, standard of care for patients who presented with non-metastatic CRPC. Again, we usually think of this for folks with a PSA that's moving quickly, doubling time less than 10 months, PSA over 2. And so, we have different agents. There are some nuances in terms of safety profile. I should have said that quality of life seems to be preserved with treatment intensification in this scenario, which is another reason for us to consider it. In terms of efficacy, on one hand, as I said, we have prolongation of metastasis survival. You have OS advantage as well, and then the quality of life. However, there are side effects that are more or less common, and we should pay attention to it. Those include things like fatigue, hypertension, falls and fractures, and for that, we kind of have a few algorithms we use in clinical practice, right? When we are actually considering bringing an anti-androgen in that scenario. And with that said, I think I'm going to pass it back to Dr. Dreicer.
So we can take this opportunity, again, PSMA PET-CT was sort of commercially available outside of the UCSF and UCLA area, sort of in the fall of last year with the fluoride agent. And again, our colleagues in the rest of the world have been using PSMA PET-CT for some time. So for us, it's a little bit of a, it's an interesting challenge, right? One of the things, and we'll talk about it because we've got questions from the audience and, there are other issues, is that, every one of the trials that you'll hear about tonight, that you've seen before, your practice philosophy was garnered from clinical trials that use conventional imaging. Not a single study, not a single drug is approved on the basis of next generation imaging that we use. So every therapy we do is going to be impacted by moving to using potentially a more sensitive issue. So earlier detection by using more sensitive assays may not mean that earlier therapeutic intervention is appropriate or beneficial. More is not always better, early is not always good as later. There's the concern of both undertreatment and overtreatment, right? Patients with high-risk disease who may receive curative intent radiotherapy with ADT might have different therapies if you see what seem to be nodes above the bifurcation. So for the next several years, we're going to be in this sort of mixed world where most of the data that we have, including even the data that was shown within the last day, came from conventional imaging. But we now have the opportunity to use more sophisticated imaging. And it may get even more confusing, right? There's an anticipation, and we'll talk about PSMA lutetium-617, which may be approved here in a relatively short period of time, and it may have a companion diagnostic, and it may require that the label for PSMA PET change to include mCRPC patients. So these are just some of the high-level issues that we need to think about. So back to this gentleman, high-risk disease, Gleason 8 disease, he winds up having biochemical failure, gets salvage radiotherapy with 6 months of ADT, now has biochemical progression, he's castrate, he's asymptomatic, and conventional imaging is without evidence of disease. Dr. Beer, he is sitting with you, wherever you are, and he wants to know what you want him to do.
Well, I think, in this setting, the drugs that are approved for treatment are based on patients at a relatively higher than average risk of progressing to metastatic disease. So those are patients with PSA doubling time of less than 10 months. I had a hard time calculating that doubling time on the basis of the data that was on that slide.
That was intentional, Dr. Beer. I didn't want you getting into the weeds, but that's a very good point. Now, let me ask you something. So let's just assume for the sake of discussion his PSA doubling time was 9.5 months.
Well, leave it to me to get into the weeds despite your intentions.
All right.
I think that's a patient where we would be discussing the prognosis and the risks and benefits of intervening. Now, I think where you're headed with this case is, would we get a more sensitive imaging study and what we do with the results? So I'd be curious if that was decided to be done in this case and see what we see.
So this case was a real dude, but this predates the ability. But let me ask you something. So I forget how old. I didn't make a Medicare age, but let's assume that either he's Medicare age or your carrier of choice is not going to hassle you. Do you get a PSMA PET in this guy? He's healthy. He's 66 years old. He's smart enough to know what the issues are, but just smart enough to know to get himself into trouble. So he's looking at you and saying, what should I be doing here? So instead of 62, he's 66. So do you do a PSMA PET?
As you know, there's very little evidence as to what to do with the result of that. I mean, there is a temptation to consider lesion-directed interventions in people who have 1, 2, or 3, a very limited number of lesions in the hope of delaying the need for more toxic systemic interventions. The evidence base for that in the non-metastatic castrate-resistant setting is nearly non-existent. So I occasionally have gotten that imaging. That would be an honest answer, but it's not part of my routine practice in this setting at this time.
Dr. Barata, what's your approach?
Yeah, great comment. I'd just like to remind the audience, right, when I think of novel imaging, and I'm thinking PSMA, right, is, I guess, the best scan in the world right now in terms of sensitivity. We usually expect about, with PSA above 1 or 1 to 2, the chances of seeing disease are pretty damn high. It was around 80% if we want to quote a number. And PSA above 2 is actually studies showing that actually the chance of seeing disease once PSA passes 2 is actually close to 100%. It's 90+%, right? So I guess, to Dr. Beer's point, this patient has not achieved, PSA of 2. So if you want to be purists, we would probably hold tight a little bit longer until we do it. It's very hard to someone comes to us and say, doc, do the best thing in the world for you, for me, whatever it's available. It's hard to go around that. So what I probably would do is, if I were to get a PSMA scan on him, I have a good chance that I'm going to see disease. That's probably going to help me, first of all, discuss with him that he's going to embark on subsequent therapy. If I see metastatic disease, which is a different discussion, what do? I would still feel comfortable to use any of the phase 3 data that I show to bring an anti-androgen because it's still clean per conventional scans. But I don't see the need right now. I think we're talking about a matter of months, right? Because this PSA is going to be, above 2 in a short period of time, and the doubling time is going to tendency, going to get shorter over time if we don't do anything about it in this setting. So I think we're talking about a couple of months. So if we order PSMA scan, get the results back, I likely he's going to get disease, and we will have to treatment intensify this patient.
So let me ask you about this sort of modulation. You actually now have same PSA total, but his PSA doubling time is 18 months, right? He just comes to you, you're seeing him,
Right.
he's bringing this data. You calculate his doubling time, it's 18 months
Right.
with the last 3 values. You got 3 values over about 9 months, right? So maybe it's a reasonable doubling time to sort of look at. Does that change whether or not you use next generation imaging? Does it impact on your discussion about intervention? I'll ask Dr. Barata first, and then I'll come back to Dr. Beer.
Sure. So if we want to, believe the data there is not great, as Dr. Beer alluded to, it gets, we're not as in a rush as much as in a different scenario. We know it's not curative, number one. Number two, I would argue that what would pull the trigger, in my opinion, to actually do something about the patient is if I'm ready to treat him. If not ready to treat him right away, right? Because we are expected to see disease. So if we're not treating him right away and we really want to meet the criteria that we have in that scenario, perhaps we should wait a bit longer. And I think doing that is safe.
Tom?
Yeah, I think this is where really an honest discussion with the patient becomes really important because, the human desire to know where the PSA is coming from is great. Every one of my patients says, is there anything we can do to figure out where it's coming from? So it gets to be pretty tough to say, well, yeah, there is, but we won't do it. But I do think that the medical and scientific evidence suggests that it's really not worth doing in this setting. And where I land with a lot of my patients is a long discussion about the fact that taking care of prostate cancer is running a marathon, not a sprint. We're going for the long term. We're going to do everything that we need to do along the way, but doing it right away is not necessarily.
Yeah, I think the phrase I use is that it's not a race to the next treatment.
Yeah.
We're not anxious to get there. All right, so let's move on. Uh-oh, he got a PSMA PET CT. All right, and you see that, let's see if I can do a little pointer, just because it's a little hard to see. So there's there's a bone met. Solitary bone met in this gentleman. All right, so you didn't order the scan, Dr. Beer. It was hoisted upon you, and he brings it with him. And now you got this. So what's up?
Tell me, I think the question really is, would lesion-directed therapy make a clinical difference for this patient?
Would lesion-directed clinical therapy make a difference for this patient, Dr. Beer?
I don't think we really know in this setting. I think in the hormone-naive setting, there have been several phase 2 trials that have looked at response and potential delay in implementation of hormonal therapy, and there is some phase 2 level evidence there. But in the castration-resistant setting, I think there's precious little data to guide us here.
So, but you use systemic, you're going to add systemic therapy, right? At this point, or are you going to just basically say, I didn't order this, you brought it, it's there, I believe that it's probably real, so what do we...
Which one of your PSA doubling time versions are we talking about now?
Which one would you like? Which one would you like? Would it matter if it was 18 months or 9 months?
Well, I think if it's 9 months and you've got a couple lesions, I think you have a case to start systemic therapy.
Got one.
Yeah.
2. All right, 2. You got 2. That's right. There was a no, 2. Somebody picked it up. It was 2. All right.
Yeah.
So you're going to treat.
If I may just add a comment.
You may.
Thank you. What I was going to say is, if this patient continues to have negative conventional scans, it's not rare that we actually go to our friends from radiation oncology. If we were convinced that we're going to radiate it, which to Dr. Beer's point, also not convinced.
Did you just suggest that you're also going to get conventional imaging after the PET?
No. What I'm saying is, this patient came with a PET because he really wanted to know, right? And the doctor that he saw didn't get the PET, and so he got a PSMA scan elsewhere, but he got conventional scans with us, right? And so at least that was my talk. And so I get to choose.
Right,
so if you have normal scans, bone in CT, and then you have a positive PSMA with a small node that you see uptake there, and then a small bone that is not seen in the conventional scans, actually a lot of times, at least I get that feedback from friends from radiation oncology, they have a hard time treating uptakes and not real lesions, if you will, right? And so that would speak, I guess, against local therapy, in addition to what Dr. Beer commented, which I agree.
But you would start him on systemic therapy?
If he meets criteria for Spartan or Prosper or Ames, I would.
So if his doubling time was 18 months, he's got those 2 lesions.
Right.
Well, actually, it's FDA approved, right? The
Correct.
approval doesn't speak to the doubling time, right?
That's correct.
So but are you treating at 18 months?
So my answer is no, because my sentence to patients is this is not a sprint, it's a marathon, which is very similar to what you both said.
Yeah.
So I wouldn't. I probably would watch it longer.
Look, these are real life dilemmas that are coming up because sometimes if you have a tool, you can't. Remember, his honorarium is dependent upon your behavior. So behave. All right. So. Just to remind us that the Prostate Conditions Education Council has lots of resources for clinicians and caregivers, and you see them listed. They have an interesting video for us to watch now that sort of gives us a sense on a patient's perspective of a prostate cancer journey. So let's take a look at that now, please.
My name is Tom Reminick. I am a prostate cancer patient. I have been diagnosed with prostate cancer at a somewhat early age. I was 54 at the time. I'm currently 65. So I have been with prostate cancer for 11 years now. There are many resources that help me in my education of prostate cancer disease and treatment. There is a lot of material that is out there, but it is somewhat of a struggle to integrate it all together and know exactly where to go for some of that information. A lot of it can be extremely technical and takes a long time to sort through some of the technical jargon that's there. But there are many places that information can be obtained. And I will identify that PCEC is one of those locations that does have very good resources that they identify. It talks about the prostate cancer disease itself and also some of the treatment options. One nice thing I like about PCEC website is that it doesn't talk down to you. It has enough detail in there to give a person that's somewhat educated on the disease even more information, yet it is not so deep that you have to go get your medical dictionary and read what some of the words are. So they actually have a very nice format associated with that. Physicians have an important role, obviously, not just in the treatment of the disease itself, but also helping the patient with education and understanding the disease itself and the nuances of that disease. But there are a lot of resources that are out there, and it is sometimes very difficult to find them, or if you do find them, to cull through that. It is enormously time-consuming. I frequently feel if the physician could narrow down some of the resources that are available to the patient, that would be tremendously helpful to the patient.
Thank you again. Just a reminder of the resources available. So this is another case. This is Mr. T. He's 71 and he shows up in your clinic 9 years prior with a PSA of 8.8. Trust biopsy for a T1C, Gleason 8 with a grade group 4, negative conventional imaging. He is treated with curative intent with external beam radiation therapy and ADT. Apparently it was planned for 2 years, but somehow it just never stopped. So he shows up. He's free of overt prostate cancer disease-related symptoms, but he certainly has his share of ADT-related issues. His most recent PSA is 8.6, and using his last 3 values, his PSA doubling time is about 4.5 months. He's castrate, he's anemic, his liver chemistries are okay. He has a germline BRCA2 mutation present when you assess it. And because you can, or because somebody did, you get a PSMA PET. And he has evidence of both bone and soft tissue metastases. So we're going to come back to that case, but before we do, Dr. Barata.
Thank you so much once again. All right, so we're going to change gears a little bit to metastatic CRPC. We're going to get a brief overview of some of the studies that we think it was relevant to share tonight. And the first of them actually is to highlight cytotoxic chemotherapy, right? There's actually, CARD was a very interesting European study, presented a couple of years ago now, and basically took patients with metastatic castration-resistant prostate cancer who progressed within a year on a prior novel hormonal therapy, before or after docetaxel. So in other words, these patients have seen docetaxel and have seen one of the oral agents, abiraterone or enzalutamide, and it basically took about 250 so patients, randomized them 1-to-1 to either cabazitaxel, standard dose, or dealer's choice of abi-or-enza, whatever the patient did not receive previously. Primary endpoint, radiographic progression-free survival. Secondary endpoints included overall survival, right? On the left side, on the right side of the screen, you'll see basically the primary and secondary endpoint. It's a positive study favoring cabazitaxel-based chemo compared with the oral agent of choice. In this case, we're talking about a median PFS around 8 months for cabazitaxel versus 3.7 months for the oral agent, and that translated in a significant OS advantage favoring also cabazitaxel. So in other words, it prolonged PFS, it prolonged overall survival. This data to me is important because it revisits the concept that chemotherapy does play a role in the management of patients with metastatic disease. And then we just saw yesterday, right, another interesting concept presented. Actually got podium yesterday, and very good presentation and discussion as well. So in this Prostate trial, this is a very interesting trial in 2 steps or 2 phases, if you will. So the first phase, patients embarked on enzalutamide at standard dose, and as long as they continue on enza more than 12 weeks, at the point of confirmed disease progression, which was defined by either serologic or radiographic progression, so either PSA of scans. They're basically randomized to a combination of enzalutamide, so you keep enzalutamide and you bring docetaxel on board, standard dose, or you offer docetaxel with prednisone and placebo. So in other words, this study tried to investigate if there's a role to maintaining a patient who's progressing by scans or PSA on enza and bring docetaxel prednisone on board versus switch him to docetaxel pred, right? And we saw the data; it was statistically significant. However, the difference in terms of PFS here was about a month or so. So it didn't meet the primary endpoint yet. We don't see a difference that gives a nice separation of the curves. As I said, it's about a month here in terms of time in terms of PFS. A word, as Dr. Dreicer alluded to, we have a word here on PSMA-based therapy. So we actually have a very cool session here at the meeting about PSMA therapy, right? Perhaps lutetium PSMA is the one leading the efforts. Well, I think we might have others to come, but in essence, the way I explain this to patients, at least, is we have a target, a very good target. PSMA means prostate-specific membrane antigen. It's overexpressed in prostate cancer cells. It's overexpressed in most of the cases. The data quotes close to 90% or so. And then you have a radioligand that releases radiation. So the way it works is it gets incorporated within the cell, and that radioligand, kills that cell. In this case, we're using a better particle. So as some of you might be very familiar with this data, this is the phase 3 trial called VISION. VISION trial was an experience. Patients were flying all over the country and actually from other places as well in the world to be enrolled in this particular study. This study enrolled patients who were heavily treated because it required 1 no more than 2 taxane-based chemo, 1 no more than 2 oral novel hormonal therapies, and they were basically randomized 2-to-1, favoring the lutetium arm to supportive care plus minus lutetium. So 2-to-1, best supportive care plus lutetium versus best supportive care. And as you can see here, you got an improvement of clinical outcomes, overall survival on the left, improved with the addition of lutetium PSMA versus a best supportive care. And then on the right side, you also see an improvement in terms of progression-free survival. This data is known, is actually published and presented. I should say that quality of life data is favorable as well, is very good indeed. And I should just add a highlight from this meeting, a data presented to the safety analysis really that look into the exposure of these patients on lutetium PSMA and what was the safety signal compared with the control. And if knowing that patients on lutetium stay on therapy almost 3 times longer, if you will, or more, when you do that exposure adjust analysis, you'll see that it seems it's actually very comparable, and we didn't find significant differences there. So as Dr. Dreicer mentioned, is under Fda Priority review. It was filed 6 months ago, so we do expect news soon. This is another trial that I actually like a lot, and this is an academic phase 2, mainly Australian study that is called Therapy. And this phase 3 trial, what he did is he asked the question, so accepting the fact that lutetium is an active agent for patients with advanced disease, the question is, how does it behave against an active agent like cabazitaxel? So in essence, that's the Therapy trial. We took patients that got prior therapy with docetaxel, no prior second generation or novel hormonal therapy, and they were randomized, 200 patients randomized to either lutetium monotherapy or cabazitaxel, right? The trial did meet, it is positive for progression-free survival, with a risk reduction of about 37%, but it's kind of interesting, I think, to look at the Kaplan-Meiers, right? Because actually the median PFS is about 5.1 in both arms, which means half of the patients did about the same in either arm, right? What is interesting, though, I think, is when we look at the survival curve here, you see these durable responders, right, represented here on the blue line, and that would translate into an advantage, and then translate into an hazard ratio that is positive favoring lutetium compared with cabazitaxel. So this is very interesting data. I don't think we have a slide about quality of life, but also the quality of life of lutetium was very favorable comparing with cabazitaxel. So to me, is a lot of lessons that we can take out of this trial. And now, moving a little bit further, I mean, of course, I think this meeting, has been heavy on genomics, the importance of genetic testing, and what can we do with it, right? So, genetic testing is really important on twofold, right? One is how we explain patients. They come to us, and we basically say, listen, we're going to do 2 types of testing. We're going to test you, the genes you were born with. That's called germline testing. And then we're also going to test the tumor, known as somatic testing. And the reason why we do that is represented in this slide. Among other things you can find, right? You will expect in terms of DNA repair gene defects, you do expect about 12% or so. This is data from Dr. Pritchard. 12% of the times you will find pathogenic or likely pathogenic alterations at the germline level, meaning you were born with. In addition to that, you expect about 20% or so of alterations, pathogenic alterations in the tumor. So if you test one, you're likely to miss some of those alterations that have treatment implications, right? And here we're just focusing on DNA repair gene defects because, the story we're going to tell in the next couple of slides is about the Parp inhibition, right? So Parp inhibitors have been explored in other areas in solid tumor world. Actually, we are a little bit behind our friends, colleagues who treat breast cancer, treat ovarian cancer, if you will. We take advantage from a problem at the genomic level that basically leads to inability to fix the mistakes in the homologular recombination machinery, if you will. So we take advantage from that, from blocking the Parp that has that responsibility. Of course, we have trials. We talked extensively, this meeting. We had PROfound phase 3 trial that basically showed us that after one novel monotherapy in the CRPC setting, offering olaparib improves all clinical outcomes compared with dealer's choice of a second oral agent. And also, we have a proof of concept phase 2 trial post-chemotherapy in the CRPC setting with rucaparib, right? And both are FDA approved. Olaparib has, regular approval. Rucaparib has kind of a breakthrough designation as an approval, but is pending results of phase 3. Active Parp inhibitors. And the good news, in addition to that, is actually more coming our way, right? So here's really quickly just to remind us that we now have the publications from both Galahad and Talapro. So Galahad tested, niraparib here. Talapro tested another PARP called talazoparib. So as you can see here, I think what's a teaching lesson from these studies, among other things, is actually you're going to see the breakdown of the response, radiographic PFS here, but the breakdown of the activity by DNA defect, right? And as you can see here, BRCA patients seem to be doing the best. Or in other words, the BRCA seems to provide a strong predictive value compared with other genomic alterations within the same group. And the reason why that's important is because when we start this conversation, right, about PARP inhibition, we didn't necessarily knew that, right? We kind of get them in the same group, but then we start learning more about the predictive value of every individual, genomic alterations, and we now know more about it. BRCA2 is different from BRCA1, that is different from ATM, different from CDK12, different from CHEK2, PALB51, et cetera, et cetera, et cetera. That's one part of the story. The other part of the story is the germline, right? There's also data suggesting that actually the powered value, the predictive value of germline is different from the predictive value of somatic alterations. And so just to say that, as anything else that works, and we see this story repeating itself in oncology, when we prove activity of molecules and therapies in advanced settings, usually refractory settings, and when they're active, we actually try and move them early on in the course of the disease. We are seeing that with many therapies. Lutetium PSMA is an example, and I believe PARP inhibitors is another example. And so just a reminder that of some of the trials, a lot of these trials are actually ongoing. We're going to have more data about. Of course, I'm not going to mention Propel and Magnitude because the good Dr. Dreicer is going to do that in a couple of seconds. Thank you.
So I want to go back and I want to ask you two questions about these trials. Let's go back to the data that was presented yesterday, and you called out the difference. Based on the way this trial was reported at a median, is this clinically relevant? Are you going to do this?
So
feel free to say no.
So
are you going to do this?
So I will answer the question, but I would just like to say, so I do believe the way Dr. Heath in the discussion presented this study was a very elegant way of doing it. She did call it, it's an option, it's not standard of care. Yeah. So that would be my answer. It is an option, standard of care. I won't use it in clinical practice because I do believe that, 50 days or so, or 60 days difference, keeping another agent.
Because there was, you didn't have time, obviously, to talk about the toxicity. Right. There's no question when you add enza to docetaxel, there's more toxicity. And that's really why I'm pushing this, is that it was an elegant study, it was a thoughtful study, but I think sometimes we see data, and we have to be a little careful. This is probably, it's statistically significant, but I'm not sure it's clinically meaningful, right?
Fully agree.
All right, now let me go back to the therapy study.
Right there.
And I think it's important to remind us, this is a 200-patient randomized study. The primary endpoint was PSA response. That's important to remember that was the primary endpoint, PSA greater than 50% response. And this study clearly was not designed to answer the distinct question about which of these two therapies should be used, right? A skeptic, and there's none of us that can be skeptical, a skeptic could say this was teeing up what would be an approved agent and a reason for you to use one before the other. This study doesn't show us that. It doesn't answer that question.
It does. And actually, to me, the way I take it from the efficacy perspective, to me, it puts things into perspective. Actually, I put things into perspective and think there's a lot of excitement, which I think is justified with PSMA-based therapy, in this case lutetium. But it also showed me another thing, is actually chemo works as well. And I think that's an important point. Now, the safety to me is the seller.
So that's a very legitimate issue, right? But I mean, I think it's important just to remind us is that that study wasn't designed really to answer the definitive sequence question. So we just need to be sort of a little thoughtful. All right, so as Dr. Barata, teed us up, is that combo studies, right? I mean, the original trial, the randomized phase 2 that led to Propel, was a provocative randomized phase 2 trial that showed Abi and olaparib improved RPFS. Had some worrisome toxicities, but it was very provocative in terms of the data. That led to Propel, and Propel and Magnitude were presented, and these other trials are in the hopper. We're going to see them. Many of you who are in the audience were certainly in the audience for these two studies. Just briefly, we don't have time to recapitulate the data. Propel was an unselected patient population randomized between Abi and olaparib versus abiraterone. Again, unselected patient population, and you see, the very impressive median RPFS here and the curve. And Magnitude was a different trial. It was both a selected population for DDR mutations, both BRCA and a range of others, as well as an unselected group. The unselected group, based on early stopping rules, the study was closed early by the IDMC because there was no benefit in unselected patients, but in selected patients with DDR mutations, there was a significant RPFS. Both trials are immature for overall survival. For those of you that were here in the audience, this generated a fair amount of back and forth by the folks who presented, some of the questions that were asked, all in good fun, no doubt, right, because they're all good friends. But I think what it highlighted is that this is an intriguing issue, and from my take, these trials are provocative, not definitive, because we don't have overall survival. And there are, from both these trials, at least conflicting data in the unselected patient population. One was sort of a negative trial, and Dr. Hagana did an elegant job of talking about the statistical issues, et cetera, but it was a negative trial and a positive trial. So I'm going to first ask Dr. Barata for his thoughts on both these trials at a high level. We don't have time to recapitulate the discussions, and I'm going to ask Dr. Beer for his thoughts.
Right, I appreciate it. I'll keep it short. So two thoughts. I love the presentation. I actually, love the fact that one was presented after the other because we can talk about it in provide context. I was going to say, that first of all, Magnitude is very helpful because the thought that we all have is actually we need a target to use a target therapy, right? And in the Parp inhibition story, we do expect to see an homologous recombination deficient effect so that a Parp inhibitor will work, right? And so far, we need that, right? So I think I would argue that we need to be proven wrong to start forgetting that concept and start using it at all. And Propel is an honest attempt to do that, but I think we're not there yet. So in summary, I do believe that Magnitude is almost, as mentioned, it was 2 trials in 1, so it does provide scientifically exactly what we thought we would see. I don't think we got surprised. If anything, it's reassuring what we saw. Whereas Propel tried to do something else, perhaps challenge the concept that I mentioned. But I do believe we need to be proven that actually, in the absence of a marker, in this case, homologous recombination deficiency, the combination does really work. I don't think we can fully state that 100% for now, knowing all the challenges that were mentioned yesterday, and we can talk more about it. But those are kind of, I guess, my 2 comments about these data.
Dr. Beer, what are your thoughts?
Well, I think one thing that's becoming clear from these studies is that in the biomarker selected patients, these drugs are moving up. These were studies with abiraterone as initial next generation hormonal therapy. That is earlier than the current indications, which for olaparib are after 1 line of next generation hormone therapy, and for rucaparib, it's after an NHT and a taxane. So this is moving it earlier, and that's encouraging. I think the biomarker negative subset of Propel is really puzzling, and I think Tia did a nice job of discussing it. But I would add that.
I mean, you mean Magnitude? Is that?
No, of Propel. The fact that there appeared to be a benefit for
I see. Okay.
olaparib in the biomarker negative population. I find that result puzzling, in the context of magnitude evidence pointing in the other direction, but also multiple prior studies, like, for example, Profound, which was biomarker only, but looked at cohort A and cohort B, with cohort B being the non-ideal mutations, if you will, not BRCA1, BRCA2, not ATM. And in that subgroup, we really didn't see much. So now we have a situation where, we've had a consistent set of studies that have shown that in BRCA1 and BRCA2, these drugs are active and important. In ATM, probably less so. And with many of these other mutations, not a clear signal. And now we're seeing folks without any mutations having a positive signal. I don't quite understand that, and we're going to need to see these data mature. We're going to need to see the survival data and a lot more thought and discussion about what that implies. I think that the case for biomarker-driven precision medicine is clear. The case for broad use of Parp inhibitors in all patients, regardless of biomarker status, I think remains to be clarified.
Thanks. There's one other point to briefly make. We didn't see, obviously, the entire data set that we published, but Propel allowed up to a year of enzalutamide use, apparently, right? Because that was allowed. We didn't see any data about the percentage of patients who received it, right? There was a remark that Dr. Saad made, which I thought was actually, it was important, because the issue is, if you have intensification, if you received an ARI, and now you've progressed, the context in both of these trials were basically designed when intensification was not being used. So first-line MCRPC, you haven't seen ABI or ENZA. What we don't know is whether or not, for example, in Propel, the patients who got enzalutamide, that the activity of ABI and olaparib is the same in patients who've not seen it. So those are, we're going to need to see what percentage of patients receive there. But Dr. Saad made a point to say that, well, and we've shown several slides tonight about the underutilization of intensification in the United States, and there's probably similar data in Europe. So what he pointed out was there are a lot of patients who aren't being treated essentially appropriately that would be candidates for this approach. So it's an interesting argument and dichotomy, but again, I would agree with my colleagues. I think we need more data here before we sort of routinely approach this, but I do think that, as Dr. Beer pointed out, if you are a BRCA2 patient and you've not received an ARI, this data is very compelling, right, to suggest that you should be receiving olaparib and abiraterone. All right, let's move along just a little bit here. Again, some additional information about genomics and genetic testing. I think it's also pretty clear that even though genomic testing in prostate cancer is on ASCO, AUA, NCCN guidelines, it doesn't happen particularly often. I'm going to ask my two colleagues what their clinical practice is. My practice is that patients with high-risk locally advanced disease or any type of initial hormone-sensitive metastatic disease, they all get germline testing. I use somatic testing later as MCRPC develops, but germline testing is a baseline for our practice. Dr. Beer, what happens up in Portland?
Yeah, that's our goal as well. And recently we had Dr. Sasha Sokolova join us from the University of Washington, and she trained with Heather Chang and is developing a dedicated genomic clinic in prostate cancer. So we're excited to have her with us in building that program. Now, does every single patient actually get it? I hope so, but there's occasionally logistical issues in implementation, but our goal is without a doubt what you've described.
Dr. Barata.
Yeah, just to keep it short, we're lucky enough to actually have someone dedicated to genetics within our clinics. We're really proud to say that. So actually, I can say 99.9% of our patients do get germline. We do discuss in the high risk. I have to say, we do 100 for metastatic is 99.9% germline. Recurrent disease, high proportion of patients, we have a strong recommendation to do the high risk. And then somatic is close to that in the advanced setting. My only, kind of be careful with that statement about somatic is because, when I have tissue, we actually end up doing tissue-based NGS. When we don't have tissue and patient is already on hormones, then the value of liquid biopsy drop significantly. Those are the cases where we don't have somatic data before they develop CRPC.
Very good. Thank you. All right, let's press on here. Just a brief mention, there's a lot of stuff in the pipeline in the context. Prostate cancer is a unique disease in that if you look at the approved agents that we have AR-targeted therapies, we have radiopharmaceuticals, we have immunotherapy with CYP-T, we have a range of different therapies. As you all know, the utility of immune checkpoint outside of the MSI-high setting has been, well, disappointing would be a soft word. It's been really underwhelming. So this data was provocative. This is work that led by the good Dr. Agarwal at the University at the Huntsman, combining cabozantinib, a drug that has been tested in advanced prostate cancer, with some interesting activity, but not enough to move the needle, as well as atezolizumab. And again, immune checkpoint as a single agent is really not particularly active. And this was a study doing in measurable disease-only patients. So this was patients, you had to have soft tissue measurable by RECIST to get on. And you see the waterfall plot. And, this was provocative data, and that has led to this particular trial, which is ongoing, again, using a pretty conventional control arm, similar to VISION and a lot of other trials about the alternative ARI. So we await this data. This would be an example, potentially, if this plays out, of the potential role to further, modulate immune therapy in a disease that's been somewhat recalcitrant. All right, so let's go back to Mr. T. 71-year-old guy, remember, 9 years ago, had a Gleason 8, got curative intent therapy, never stopped his ADT, doesn't really know why, which is, of course, not uncommon. Sometimes you just don't know why. It's just easier to do it. And now he is castrate. He's got the anemia. He's got a shortening PSA doubling time. He's got a BRCA2 mutation. And again, reasons beyond your control. He has a PET CT that shows disease. So we'll start with Dr. Barata. What's, how are you approaching this gentleman at this point with MCRPC?
Right. So, of course, staging is important. Right now, we know he has CRPC. We also know something very important. He had a germline BRCA2, which might have implications for future. I would like to know the extent of the disease, if any, right? To know if he's met that
so that,
CRPC.
just to remind us, the PSMA PET showed, 3 or 4 bone mets and some soft tissue nodal metastases.
Oh, gotcha. Okay, got it. So that's the result. Okay,
Yeah.
so in that scenario, right, I do think that, likely going to be offered NHT, right, in that setting. And, the approval right now is probably EMSA, ABI,
So you came home for the meeting.
Right.
Is
That's
this the
right.
guy? Is this the guy you're going to do olaparib?
Right, I do expect, I do think that, although I don't think he's incorrect, but I would argue that I do have level 1 data with a sequence of, Abirenza followed by olaparib. In this case, I know it's going to work, and I know it makes them live longer. And so I try to be data-driven as much as possible. I don't think Propel Magnitude are ready for prime time just yet. And so, but I don't think it's wrong to consider a combo, but I would use survival data to do a sequence.
Dr. Beer, your thoughts?
Well, I think if there is a patient where you'd try it, this would be it. It's a germline BRCA2, so that's very likely biologically significant. I tend to be a bit conservative, but adopting new strategies. I think I'd come down similar to Dr. Barata and start the patient on an NHT therapy and plan on a Parp inhibitor being next. We don't know yet whether sequential use is going to yield similar results in terms of overall survival. This is RPFS data only. But, I think one could make a case for 2-drug therapy. If one wanted to be rational and aggressive, this is the one setting where one could consider 2-drug therapy with these new data.
So,
What would you do, Dr. Dreicer?
what would I do? Well, I kind of would side with Dr. Barata. I'm not, let me just step back for a second. One of the things that I was impressed with by Propel, in a good way, despite my general skepticism of things, that's what happens when you get old, you get cranky about stuff like that. But the toxicity profile was not as worrisome, at least in this report, as the original randomized phase 2. Now, that said, we've all used PARPs in prostate cancer, and we all know PARPs are not easy drugs to give to patients with advanced prostate cancer. We just know this because they kind of, they remind me of TKIs and kidney cancer. They kind of grind you into the ground over time. So I'm still a little worried when you get into the real world, right? We all recognize that patients that were on Propel are selected because they went on clinical trials, and we all get this. And when you get out in the real world, but using a PARP earlier, I mean, the danger of waiting with PARPs is, especially in a BRCA2 mutation germline, is they need to get this therapy because this is a targeted agent and he's best likely to sort of tolerate it. So I guess I would be a little reluctant to try to pile on at this point. I would treat him with with an ARI, and then my next therapy would be olaparib. All right, so we've got a few minutes left. We've got questions from the audience, so I'm going to sort of pose them. Some of them we've sort of tied on a little bit. Let me see what. Yeah, just to remind us that it takes a village to take care of prostate cancer, right? We talk about, all of us work at academic centers. We have important relationships with our urology colleagues, our rad-onc colleagues, and a whole range of the team that helps take care of this patient. We've heard from the Prostate Education Council about the need for, information, et cetera. So, again, as we're addressing the questions, make sure that Dr. Barata gets his honorarium and fill out your things, all right? So, all right, Dr. Beer, can you forego a biopsy of a strongly positive PSMA PET lesion? Is it that good that as an initial presentation, remember that patient that I said had one lesion that really had two? Let's say he only had one, right? That's his first evidence of metastatic disease. Is that good enough to make a treatment decision?
I think we're still learning about that, but one of the early studies with the F18 compound looked at correct localization rate, and I forget if it was the Osprey study. The names escape me, but they used a combined standard of truth of either pathologic confirmation or response to lesion-directed radiation. And with that standard, the scans identified lesions accurately more than 80% of the time. Was between 80 and 90%. So I think perhaps you can, but I'm still in a learning curve on this. Remember, these imaging modalities are really just entering the market here.
All right, so let me ask you, at OHSU, not investigational, which of the PSMA PET-CT assays are you using at your shop? Is it the gallium or the fluoride?
Right now, well, we have both, but most of the scans are the fluoride scans.
Right.
At Tulane?
We get gallium for a while, and now fluoride is also an option, yeah. We actually do have both.
All right, so...
Can I just highlight the importance of the biopsy? I think we can skip a biopsy, right, to confirm that. However, I was just going to, bring it up that the benefit of the advantage of a biopsy, it goes beyond just the fact to prove it's prostate cancer, right? There's a value to that. Actually, part of that was a discussion yesterday, whether or not liquid biopsy does miss sometimes DNA repair defects. I think it's important for a couple of reasons, to have a tissue confirmation, information about histology, information about molecular profiling that helps us to think ahead and actually plan next steps, and so that's important.
So what's but this was a bone lesion, right?
Right.
So what's the yield? What's the yield?
That's right.
For this?
With that said, we got to be careful with the decalcification. We got to be careful with a lesion only in the bone. So that would be my reluctance. But if it's feasible, and especially outside the bone, having confirmation of metastatic disease with tissue when feasible is something to consider.
So back to the gallium and fluoride, Dr. Beer, what's your best guess? Is any of this going to shake out, or is it going to be whatever works best in your shop? I mean, do you think that, again, we're not experts, but we clearly have some exposure to this. Do you think the differences in gallium and fluoride-based assays are going to move the needle enough that you choose one versus the other? Or it's basically logistics and cost because the tests are basically, the assay results will be so similar?
I think it's the latter. We have the benefit of really having a wonderful nuclear medicine group, and we work very closely with them. So we've actually had these discussions amongst ourselves with our nuclear medicine colleagues. And the view is that the F-18 currently has somewhat higher resolution images, but in terms of actual lesion detection capacity, they're really very, very similar. And it's been the view of our folks, and I have every confidence in their judgment that clinically the two are largely interchangeable.
Dr. Barata?
Yeah, no, I agree. I think it's going to be a matter of access, to be honest. I have the feeling that the fluorum is an advantage.
Yeah, just the point, I mean, we actually don't have both because at the University of Virginia, because of our location, gallium has a shorter half-life, so the fluoride molecule has a longer half-life. So logistically, for our nuclear medicine group, they're going to work with the fluoride assay until gallium becomes so ubiquitous there's no issue there. So I think this is an evolving construct. There are going to be other PSMA assays available, and I think it'll become a commercial decision. All right, let me ask you another question here. Here's a question that I can take a crack at. Does the AE profile of cabo-atezo and mCRPC mimic its, I'm going to assume, the toxicity profile in other tumor types? So I was involved in these studies and treated patients with both urothelial as well as kidney cancer. And the answer is, yeah, for the most part, the toxicity, first of all, I must tell you, I was very skeptical to begin with. I mean, I was involved with cabo and prostate cancer. Now, it was dosed at 60. This study dosed at 40. Hard to give humans cabo at 60 and have them sort of, walk around. Some patients got just completely pile-driven into the ground, but I also had 2 patients who were on the drug for this combo for 2 years. So it was actually, the toxicity was relatively surprising, and it was not disease-specific. So would you, this is for Dr. Barata, would you do somatic testing right at the time of initial diagnosis, or wait until patients develop resistance to perhaps first or second-line treatment? Somatic testing.
Somatic, yeah. So if I have tissue available, so I do both for research purposes, I should say that. There's no cost to patients, so we actually are fortunate enough saying that, and I don't want to run away from the question. If I have tissue available, I do. And the reason why I do, because, I'll do germline and somatic. So I do somatic in that setting, the hormone-sensitive space. And the reason for that, because I plan ahead, right? Not only trials that I might have available later on, but also I'm thinking precision medicine. There's going to be a role for that, right? Knowing they might not be 100% right when time comes, because I'm going to expose these patients to a number of different therapies, and there's always some tumor, clonal heterogeneity. But saying that, I try to do that. With liquid biopsy, it'll be different. At the time, there's a couple of challenges with liquid biopsy, me being minimally invasive, which is a good thing. But you really need to have tumor circulating DNA to detect. And so my experience has been in the early setting, at a time of M hormone sensitive disease, if, as long as you start them on something, especially, LHRH, if not Casdex, whatever you want to do, a few weeks later, the ability to detect ctDNA drops significantly. So in that scenario, we then do it at time of progression to CRPC.
Dr. Beer, your thoughts about that?
I think we still don't have enough data on the evolution of the genomics of prostate cancer as it advances, but we tend to get the tissue analysis at the CRPC stage, and we will even target specific lesions that are, if a patient develops new liver lesions, for example, we will be quite interested in the biology of those lesions, and we'll want to biopsy them at that time. Mm-hmm. So our bias is towards analysis closer to when you'd use the data for somatic mutations. Germline, of course, we would go right from the beginning.
So this is a question that I think, it's an interesting question. So Dr. Beer, how do you best define a DDR positive patient? What is that? What's that definition to you clinically at this point? And I'm going to assume the question is being asked about, from a therapeutic perspective, what does that patient look like today? Let's talk about monotherapy with Parp based on approved therapy.
Yeah. So I'm going to understand that question as looking at the different mutations and talking about the differences between them as opposed to technical questions about different assays. So if that's the question, then I think for me, BRCA1, BRCA2, PALB2, maybe RAD51 mutated patients are therapeutically actionable. I've been really disappointed in ATM. It's the second or third most common mutation, and the response rate consistently is pretty darn low. And you and I are old enough, Dr. Dreicer, to remember that you can get a 10% response rate with oral etoposide or oral Cytoxan in prostate cancer. And so getting
or prednisone.
Right.
Or prednisone.
So getting a 10% response rate with an expensive new targeted drug because you have an ATM mutation is just not very compelling from my perspective. So I think we need to learn a lot more about these other mutations, and hopefully we'll develop strategies that are more effective. But I really focus on BRCA, PALB2, and RAD51.
So I agree with Dr. Beer. I should just add one or two comments to that. It does help me regardless, and I was going to say why, right? So yes, we now know more, and we know what to predict, right? It's because the thought process is we don't save the best therapies for later, and so we're trying to predict what's going to be the outcome of offering a Parp inhibitor. And I think what we're all saying is we have a patient in the setting for a Parp inhibitor, in this case would be post-Abiranes in the MCRPC space, right? There's a first approval, olaparib, for example. If I have a BRCA2 patient, I think most of us will offer olaparib. If we have a CHEK2, for instance, we probably, maybe not. But also that will depend if the patient is interested in chemotherapy or not, and the patient is symptomatic or not. What's the room for us to control the disease? And so the reason why I say that, because I like to bring up the data from Anna Parishio, Paul Korn et al., right, with platinum-based carbocabazine. The reason I bring that up, not because of the aggressive variant piece of the P53RB1P10, but also because it's an association with that aggressive variant prostate cancer, actually with DNA repair defects. So there's actually a lot of times I've done, instead of a PARP, when I think there's a lower chance of success, perhaps ATM is a good example, or CHEK12, what I'm going to do, or CDK12, excuse me, what I can do is actually consider bringing in a platinum in addition to taxane-based chemo. So I think the discussion goes beyond the PARP inhibition, and it does allow us to think about what's going to happen in terms of sequencing therapies and what therapies to choose.
So with that, we're going to thank those of you who have joined us virtually, and certainly those of you who have joined us this evening for spending a little bit of time. This is where you can get your post-test evaluation and credit and download slides and practice aids. And again, thank you very much for joining us and for the supporters of the program.
Thank you. Have a good night.